Program Manager for LULAC, the League of United Latin American Citizens, the oldest and largest grassroots civil rights organization for Hispanics in the United States and Puerto Rico. LULAC's mission is to promote the economic status, educational attainment, political influence, housing, health, and civil rights of the Hispanic population in the United States. Throughout some of the last years, one of the most pressing issues affecting Latinos is health. Disparities in access, quality of service, and the burden of preventable chronic illnesses are rampant. Obesity, heart disease, cancer, diabetes, and strokes continue to be prevalent health issues within the Latino community. Our health programs focus on improving health outcomes through engaging our local councils, our partners, and corporate sponsors in campaigns dedicated to raising awareness and inspiring healthy lifestyles to change our communities. Through our Latinos Living Healthy program, we aim to bring solutions to issues that affect the Latino community across the country. Our programs allow Latinos equal access to make choices that allow them to live long and healthy lives, regardless of ethnicity, education level, or income. With this in mind, LULAC has created the Healthy Communities program to promote access to healthy environments and to target the root cause of local inequities. Today, we will be learning more about obesity and the effects it has, especially among the Latino community. We have invited two wonderful speakers to be with us today, and I hope that you all learn, engage, and visit our webpage to learn a little bit more about the work that we are doing. A huge thank you to Novo Novartis for being able to sponsor this wonderful event today. I'd like to take a moment to introduce Abia Ailleen, our moderator, our Instagram influencer and plus size model that will be moderating today's event.
Hi, everyone. Nice to see you all. I am so excited and grateful to be here. Thank you so much to LULAC and Celeste for pitching me. This is something super important to me, as I myself have struggled with health and weight for almost my whole life. So I'm excited to get this started. Obesity is a major contributor to serious health conditions in children and adults, especially in the Latino community. Obesity is more prevalent in Latinos at a 47% than any other ethnic or racial minority group, and Hispanics are 1.2 times more likely to have obesity than non-Hispanic whites. Obesity is a chronic disease impacting dozens of comorbidities, and it is time to confront its broad impacts. As one of the fastest growing segments of the population, there are several factors that contribute to obesity rates being higher in the Latino community, such as metabolic, environmental, cultural, socioeconomic factors. Hispanic communities often lack access to sources of healthy food. Nearly 1/3 of Latinos eat 2 or fewer servings of fruits and vegetables a day. Latino families may also have different standards and ideals for what constitutes a healthy child. As a Latina myself, man, I can put my hand up to that, because that is so true. Low-income Latinos are more likely to view physical activity and a good appetite as markers of health status than growth charts in being able to define a child's weight. I would love to start off by introducing our panelists joining us today. We have Dr. Jose Aleman Diaz, an endocrinologist in New York, who is affiliated with multiple hospitals in the New York area, including NYU Langone Hospital and Memorial Sloan Kettering Cancer Center. He received his medical degree from Harvard Medical School. His specialties include the area of endocrinology, diabetes, and metabolism. Endocrinologists treat disorders of the hormone-secreting glands that regulate countless body functions. These ailments include diabetes, thyroid ailments, metabolic and nutritional disorders, pituitary diseases, and menstrual and sexual problems. Thank you so much, Dr. Aleman Diaz, for being here. I would love to start off with a little bit of my own story. I'm 23 years old. Oh my goodness. I've always been an active person. Thankfully, my parents always pushed onto us that school cannot be the only thing you do. You have to stay active. So my parents would always put us in sports. Some sports I didn't like, some sports I hated, and some sports I loved. I found that, so I actually was born with heart murmurs that actually affected me throughout my whole life. I had to go into emergency surgery when I was born. And with that being said, I actually lived a lot of my childhood with severe asthma, especially, I guess, activity-induced asthma. I wasn't even able to run a mile without stopping, taking my inhaler. Once I got into swimming and water polo, I found that it almost cured my asthma in a way. I think just exercising my cardiovascular health really improved my, I would say, quality of life majorly, in a major way. Weight, on another hand, has always been a struggle for me. One, because like I said earlier, in the Latino community, weight is a big issue, and a lot of the times our families and the ones we love don't address it in a way that will actually make us want to be healthy. For example, I'm 5'8". I'm 5'8". I've always been, I would say I was 5'8" since I was in middle school. So I was always the bigger girl. I was always taller. And that made me very uncomfortable. And it put on those insecurities early on in life. So my parents' way of telling me, oh, maybe you shouldn't eat that is, no, you can't have that. Or another one. And it was just things like that that kind of almost made me want to be a closet eater. So during my early adulthood, I would say when I was 20, I gained about 25 pounds heavier than I am now. And that was enough to make me change my entire lifestyle. I found that I couldn't go up a flight of stairs without having to stop. I felt like my chest was so tight whenever I tried to work out. And of course, I just didn't like the way I look. I felt uncomfortable. I can feel the inflammation in my body, which was a huge thing for me. And I was just really encouraged to get healthy. I got a sustainable, healthy lifestyle, which not only affected me physically, but mentally, emotionally. And I actually really enjoy where I am right now with the way I view myself and how I can help others view their bodies as well. So with that being said, I would love to dialogue with you, Dr. Aleman Diaz.
Thank you, Abia, for sharing your story and how the perceptions of weight have affected your journey and kind of your dealing with weight and to increase your health. As you very well introduced, I am an endocrinologist. I'll give a little bit of my personal story within the few minutes I have before we continue the dialogue and tell you what I do. I am originally from Puerto Rico, and I do come from a family with obesity as well. Fortunately, none of my immediate family has developed complications from their weight, but we were always on the larger side. And that also has been a struggle in trying to maintain what I would consider a healthy weight for myself. I came to the mainland to go to college, and as you mentioned, went to Harvard Medical School, did research, trying to study metabolism, and that drew me to the subspecialty of endocrinology, which, as you mentioned, studies hormones and focuses on our metabolism, the way our body uses and distributes energy. And that's integrally important to how we think about the disease of obesity. I want to make the distinction between weight and obesity. So weight is what you get on the scale. It's a measurement we get in the doctor's office, or you get in your home. But I and the World Health Organization define obesity as a disease, specifically the excess fat accumulation that leads to complications. And that's very important because we all come in different sizes. And as you alluded to, there are biases that come with addressing weight, cultural, personal, and otherwise. But the moment the weight starts impacting your health, whether it be shortness of breath, as you mentioned, or more commonly abnormal blood sugar or prediabetes, which is very common, I think that's a distinction at which we probably should think about addressing it with many of the tools we have, which include nutritionists, include behavioral colleagues like psychologists, and if needed, some of our medical colleagues like endocrinologists or surgeons, for instance. To that end, I see patients at NYU Langone Health, but also at the Veterans Hospital in 23rd Street in New York, where patients are referred to me by my colleagues because they've developed complications like type 2 diabetes from their weight. And we try to treat them in a way that treats their diabetes, their abnormally high blood sugar, and the weight simultaneously because they go hand in hand. Okay. My other hat when I'm not caring for patients is to be a researcher and is to understand how does obesity cause disease. We know that obesity, the disease of obesity leads to abnormally high blood sugar that leads to diabetes. We are interested in the tissue itself, the fat cells that store energy and how they talk to other cells in our immune system to produce a low grade of inflammation that we think predisposes to diseases like diabetes, cardiovascular disease, cancer, and now more recently, COVID or COVID complications. Obesity has become the most important preventable cause of disease in the United States. It actually overtook smoking in the last few years. And I think the onus is on those of us in the medical profession and everyone to really address it in a multidisciplinary way, to be able to address what is a disease of our environment, an environment where we have readily available calories, but also our predisposition to store that energy that kept us safe long ago. So that's by way of my short introduction. And thank you.
Thank you, Dr. Aleman. So I have some questions for you. What are the different categories of obesity?
Mm-hmm. So going back to what I mentioned initially, I think the most important distinction is whether obesity or excess weight causes disease complications. However, in the medical world, we use your weight and we use a value called the body mass index, which is your weight divided by your height squared, as a way to capture what we think is your overall fat content, how much fat you have in your body. That is a different measure called adiposity, which is a mouthful, and it's hard for me to explain to patients. But we think adiposity is part of the reason why patients develop complications from their excess weight. Where you store your fat, specifically if you store it in your organs, like your liver, for instance. Obesity is becoming the most common cause of liver transplant, for instance, in the US. So by a body mass index, a normal body mass index we define as between 18 and 25. This is kilograms divided by your height in meters squared. And then class 1 obesity, which I should say overweight, is between 25 and 29.9. Class 1 is 30 to 34.9. Class 2 is 35 to 39.9. And class 3 obesity is BMI greater than 40. These are not so important for most patients. They are important for those of us that care for patients because they dictate treatment. That is, the spectrum of care for obesity includes behavioral, includes nutrition, but it also includes medicines and surgery. And some of the medicines and surgery that are available for treatment are dictated by which body mass index you have. And obviously the risk of developing complications increases as you go up in classes of obesity.
Wow, interesting. As you were saying that, I just thought about how I watch a lot of those medical shows, and people who want to get gastric bypass surgery, they actually do have to lose a certain amount of weight, correct? Before they can even safely get the procedure done.
Yeah. So I'm not a surgeon, but I refer to bariatric surgery quite frequently, and I'll speak briefly to that kind of from the patient perspective. Bariatric surgery, the current indications for bariatric surgery would be class 3 obesity, so BMI greater than 40, or class 2 obesity, BMI 35 or greater, with complications like diabetes, osteoarthritis, sleep apnea, and many other diseases that come with the excess weight. Many surgeons in the United States do ask patients to lose a small amount of weight leading up to the surgery, because a common complication of the adiposity of obesity is a fatty liver. So your liver becomes enlarged, and it becomes enlarged in a way that makes the surgery more difficult. So they do that for a very practical reason. Other countries don't do this. In Europe, this is not done, but it's customary in the US to ask patients to lose a small amount of weight in the order 5% or less from where they are.
Wow, interesting. Thank you so much for that. So Dr. Aleman, what are the current rates of obesity among the Latino community? And are we making progress in curbing obesity in our community?
Yeah, so I think, as you mentioned in the introduction, the rates of obesity in the Latino population are higher than in the general population. So it's about 47% compared to, depending on the study, between 30 to 35%. I should say, unfortunately, we're not making progress in the general or in the Latino population. The rates of obesity are increasing, and they are leading to increases in rates of predisposition to diabetes or prediabetes. This has a lot to do with a number of different factors. I would mention we live in an environment that we have ready access to calories that are really tasty and they're hard to resist. But our bodies were built over hundreds of thousands, millions of years to store energy. So the combination of having ready access to calories and our body's predisposition to store that kept us alive now hurts us. And you can show that over the last 30 years, as the average number of calories in a meal has increased, the rates of obesity have increased. So very much directly related to what we put in. There are many other factors that contribute to it. We understand a lot about the hormones that contribute to obesity. We understand a lot about the genetics, that what we inherit from our parents. Obesity is highly heritable. If you have two twins, and one has obesity by the definitions we mentioned before, the other one is 90% likely to have obesity. So so we're understanding a lot more, but it starts with our environment, and then it is exacerbated by other factors.
Wow, wow, I didn't know that. Thank you, Dr. Aleman. What are the kind of health problems that can develop from being overweight and obese? Yeah,
so this is very much my cup of tea. This is what I deal with every day that I see patients. Most notably diabetes. So diabetes, just in lay terms, is having abnormally high blood sugar. And that occurs because a hormone in our body, insulin, doesn't work the way it's supposed to work, either because the organs don't respond to it or because the pancreas, which makes it, doesn't make enough of it. That's the reason why we give insulin to treat patients with diabetes. Many others, high blood pressure, the diabetes and the high blood pressure predisposed to heart disease, high cholesterol, so strokes, gallbladder disease, arthritis, sleep apnea, asthma, as you mentioned, tends to run along in children with obesity, kidney disease and kidney failure. Diabetes, obesity, and causing diabetes is the most common cause of renal failure, of kidney failure in the US, and needing dialysis. And I'll add to that list cancer. Actually, we now understand that obesity is an important preventable cause of cancer, which wasn't appreciated until recently.
Wow, that is amazing. Ooh, what a wake-up call. I say that because cancer is actually very prevalent in my family.
Yeah, it's not all cancers, I should mention, but there are cancers that are obesity associated, and we're also learning about those.
Wow. Wow. The disproportionate number of minority groups with obesity have also higher levels of mortality from COVID-19. To my understanding, this is something that I have actually been really interested in because, the pandemic. We have seen, everybody talks about age and everybody talks about, well, if you have predisposition diseases, but a lot of the times we skip over obesity as one of those diseases. Yeah. And I have seen that those who do suffer with obesity, the mortality rate for that group has been higher across the board, and any group, does not even just minority.
Absolutely. It is an important risk factor for worse COVID-19 infection outcomes, all the way from needing medical care, hospitalization, needing critical care, or death. And actually, some of the investigators in our institution, including Chris Petrilli, showed very early on, and Jen Leiter, I should mention as well, showed very early on that obesity defined by body mass index was or gave increased risk of COVID complications. That has borne out in many countries. It was best studied in the US because the US had higher rates of obesity than the earlier pandemic countries like China or Italy, for instance. But that has borne out to be the case, so much so that it raises our antenna as providers for patients that might need more medical care, and is now one of the indications to pursue COVID-19 vaccination, obesity by itself. We have contributed to that effort a little bit. I worked in the COVID wards during the height of the New York pandemic between March and May of last year. In the veteran population, we find that obesity and diabetes go hand in hand as risk factors for worse COVID-19 outcomes. In our hands, at least, diabetes is a higher risk factor, but obesity is a very significant risk factor. And the term what we use in the literature is they synergize, they talk to each other and they increase each other, this risk.
Wow. Oh, Dr. Aleman, we applaud you for your work in the COVID wards. I can't imagine what that's like. Thank you so much for that.
You're welcome. I'll come back to one point you mentioned about the Latino population. So in terms of COVID and complications in the Latino population, we thought maybe the Latino population has a combination of increased obesity, diabetes, in addition to perhaps less access to care. And that would certainly explain some of the disparities that we're seeing. Early work from Benga Ogedegbe and our institution as well has shown that most of the differences can be attributed to access to care. So the different health disparities, say in the Latino and the Black population, are because of lack of access to care. And for instance, in our institution at NYU, the early experience was that our Black patients did better. So it varies from place to place.
Wow. Dr. Aleman, can you elaborate on the financial toll of obesity?
Yes. So obesity is the kind of medical problem that can threaten to bankrupt the U.S. healthcare system. And this is very severe in terms of the medical toll. Some estimates put it at around $480 to $500 billion, and increases medical costs in the order of several $1,000s. An estimate is $2,500 per person if that person has obesity in addition to their medical problems.
Wow. So not only is it almost detrimental, it's also very expensive.
Yes, it is expensive. And I think that's an argument that's persuasive. And actually, there's colleagues that are studying, does it make sense to give financial incentives for people to do the right thing, and in terms of what they put in? So it is expensive, and it's downstream cost. You asked earlier about bariatric surgery. So the countries that do bariatric surgery, which is the best treatment we have for diabetes related to obesity, save money in the long run, because you've cut the cost of that person potentially getting diabetes and all the heart disease and other issues that come down the line. The base data for that comes from Europe, that have followed this for a long time. But we know that losing and maintaining your weight over long periods of time saves each person and saves the system money.
Wow. So it's a win-win for everybody.
Yes.
Wow, thank you. Dr. Aleman, what exactly causes obesity?
Yes. So that's $1 million question. There's lots of us trying to understand that from many different aspects. As I mentioned, I think the environment is among the most important, if not the most important factor. And that is manifested in, a poor, highly caloric diet. I would call it a poorly nutritious, highly caloric diet that can manifest in areas like food deserts, when our community doesn't have access to fresh foods that are nutritious and have lower calorie density. Lack of exercise and an active lifestyle is secondary to that. I think it is a common misconception that you can lose a lot of weight through exercise from TV shows and other things. But the calorie deficit, the number of calories that you expend in the treadmill, you can very easily undo with a soft drink or with a donut. Anybody that's been on a treadmill knows that. So what I tell my patients is that it really starts with nutrition, and exercise is great for you. It does wonderful things, most important for maintaining your weight, okay? I mentioned family history earlier, and we understand a lot about the genetics of obesity. There's rare 1 in a million type genetic mutations that cause obesity, some of which we have treatment for in the form of different hormones. But this is not common obesity that most of our family members have. Like I mentioned, it is true that it is genetically inherited, but it's many genes that we inherit together from our parents that predispose them. And then, psychological factors. Food is comfortable. It can provide comfort. So we address that with our behavioral colleagues. Comorbid mental health issues like depression can change how we put in. Access to preventative health and being reminded of the importance of what we put in. And then, social determinants of health disparities proper that come about because of lack of access to care, differences in say, diet and other aspects.
Wow. I would just like to share a little bit of my own experience about that. When it comes to poor diet, I remember early on, I qualified for the free lunch program at schools. I wouldn't say we were necessarily low income, but low enough to get the free lunch, which was another meal that my parents didn't have to provide for me. So it helped us a lot. I will say, though, as much as we tried to push health onto our children, the lunches were not at all healthy. I can't remember the lunches being healthy or enjoyable whatsoever. Yeah. And not only that, the free lunches weren't healthy, but also a lot of schools make money selling chips and cookies and juices and ices. And I just remember that being a lot of my high school experience. Was I'm actually going to skip out on the lunch today and just get a cookie or get a bag of chips. And I just always thought it was okay. Well, my mom can't tell me I can't eat it because she's not here. So I think that's where a lot of honestly, closeted eating starts too, because I know that's where mine started. I always felt a little bit, oh man, I just don't want to hear my parents telling me, well, you shouldn't eat this. So I'm just going to eat it at school.
No, I absolutely hear you. I'm a parent of 2 young children, and motivating them to eat in a healthy way is very challenging. Any parent can tell you that. And your experience is common. Unfortunately, the school lunch programs in the past did not offer healthier options. That is changing, and that's an area that the U.S. Department of Agriculture and many agencies are trying to target, because, as you mentioned, that is an important meal for many of our country's children, and it can potentially impact childhood obesity, which is also increasing.
Right. Especially because I knew a lot of friends who that was quite literally the only meal they were getting a day. So if the only meal they're getting a day isn't nutritionally valuable, they're still going to consume it because, like I said, it's the only meal they're going to get.
Yeah.
So, okay, this is also my cup of tea. Battling the stigma. How can we focus more on person-centered language when diagnosing, treating, and living with obesity? As someone who is, so I am a plus size model. For those who are wondering, I'm a size 12. A lot of people always tell me, oh, well, you're not plus size. And I always tell them, well, take that up with corporate America, because according to the fashion industry, I am plus size. In fact, for many of you who don't know, plus size in the industry is considered anything that is a size 8 and above. I can't remember the last time I was a size 8. So anything that is a size 8 and above is considered plus size, especially when it comes to proportions. So Dr. Aleman, can you give us a little more info on just how we can focus more on the language?
Absolutely. Obesity stigma occurs at many different levels, and it involves actions against people with obesity that exclude or marginalize, and in large part it leads to inequities, and it leads to inequities all the way through the medical system, including, for instance, we were talking about bariatric surgery. The rates of bariatric surgery are extremely low, are in the order of 1%. So because many of my colleagues don't perceive obesity as a serious disease. But there's many other ways. People don't receive adequate health care. They might be discriminated in the workplace, in workplace, the fashion industry, as you're mentioning, in education settings. There are things that we can do. And I trained in obesity medicine, and I still catch myself because it's ingrained in us, the use of person-centered language. So I very much try to describe patients or persons with obesity as opposed to the adjective obese, because that makes the distinction that it is a condition or a disease that the person has rather than a quality of the person, okay? I think that goes a long way to help patients feel empowered to address it as an issue. And then I will say that, in the United States, we are used to larger frames, and anybody who comes from say Europe or other parts of the world will tell you that. So part of it is redefining what we think a healthy weight is. We all come in different sizes, and I think we have to be aware of that. What I care when a patient comes in is that is your weight affecting your health? And if it's not, you live your life, but I just want to make you aware that there can be consequences down the road, and it's A, B, and C, as we discussed earlier. But yeah, person-centered language, treating obesity as a serious disease that has complications, because the downstream health and financial consequences are quite severe.
Oops. Oh, there we go. Thank you, Dr. Aleman. How do you think this can affect us in social settings? Like, as in, whenever I think of this question, I think of just how someone who is struggling with severe obesity, I know that a lot of the times they are forced to get 2 plane tickets. So how do you think the stigma and the negative connotation of the word being obese can affect their prognosis?
Yes, absolutely. It's I think that's one way in which the health inequities start.
Okay.
Because if you don't think it's serious enough and you attribute it to the person, then you don't think it's serious enough to be treated. So I think it starts there. In our offices, for instance, we make the effort to have chairs that can accommodate our patients that might have more severe classes of obesity. And I think that's a general movement across a lot of the healthcare and even some of the public kind of government settings that I've seen. Airlines, frankly, have been late to the game. They have real space constraints, but they haven't really accommodated well to that. But I think I try to tell my patients to educate their colleagues or their friends, family about the patient-centered language, about taking away the connotation of the adjective and empowering them to really think that this is something that can be addressed and that there are some of us who can help.
Interesting. I also have another question that my own personal question.
Mhm.
How do you think somebody suffering with obesity, if they are surrounded by people who also suffer from obesity, do you think their prognosis is affected, and how?
Yes. So the best data that occurs that we have in that perspective is from children, because children really reflect the home environment of their family. And if you have a larger size family that may or may not have complications, that very much tracks with whether the child is more likely to develop childhood obesity. The wonderful thing about children is that they often get better. So what my colleagues that are pediatricians try to address with patients, with the family, so you have to address the family, you have to involve the parents in treating it, and stressing the importance of changing the family meal plan to improve the nutritional quality and decrease the quantity. So having more of those highly nutritious, lower calorie density foods for the family, not just for the child. And doing interventions as a family that can help. For children, physical activity is very important. They're supposed to be active every day for an hour. That's certainly encouraged in schools, and so encouraging physical activity both individually and even as a family. So absolutely, your environment and your immediate circle and proximity will impact and increase your rates of having obesity, and it has to be treated as an environment, as a local environment.
Yeah, I think sometimes for myself, I was really young when this happened, but this is a story or a situation that is always brought up in my family. My great grandmother, she was an amazing cook, just like all of our great grandmothers. And she cooked a lot of traditional Mexican dishes, which a lot of the times, if some may not know, it involves lard, it involves a lot of high calorie foods for every meal, high calorie, low nutritional foods for every meal. One day, my great grandfather suffered a really bad heart attack. And that is when everything changed. My grandma adopted a new way of cooking. She just was never the same in the kitchen. She never used lard again. She never, it was a lot of just making small changes, but that were sustainable through a long period of time. And I will say my great grandfather lived. He had a heart attack. He lived for about almost 17 years after his heart attack with 30% of his heart. So those lifestyle changes, I think, really are what made him survive so long. And the doctors told him, you only have 6 months to live. They told him you have 6 months to live. So my great grandfather outlived those 6 months. And those eating habits actually rolled over into all of our lifestyles.
Yeah.
So my grandma's eating started changing. My mom's eating started changing. And I know a lot of healthy recipes and meals because of my mom, and because she taught me you should incorporate fruits and vegetables in your meals every single day. So I am grateful for that. Although I will say, I wish a lot of our community didn't have to get to those stages to start making changes.
No, thank you for sharing that story of the impact that one lifestyle change can have in a family, and you can imagine kind of in a community that way. What I often, so heart attacks, major medical events often provide that opportunities. Diagnosing diabetes, also we stress the importance of following a diabetic diet. And what I tell my patients oftentimes is that it is important to make the changes small enough that they can be sustainable. This is part of the historical background that we bring to the table. Our forefathers may not have had 3 meals a day, and they needed to get their calories in 1 or 2 meals, and that's where that culinary tradition might come from. That certainly happens in Puerto Rico as well, where I'm from. But I think what we can do is modify it so that it's sustainable for us. Simple changes that I ask my patients, often in the context of diabetes, changing your bread from white to brown, changing your rice from white to brown, decreasing the portions. As you mentioned, Abia, increasing your intake of vegetables, ideally with every meal. In the context of diabetes, controlling the carbs is additionally important, and many of our original countries' diets in the Hispanic community are high in carbs. It doesn't mean that a high carb diet is necessarily bad, but it has to be tailored to your specific context.
Interesting. Yeah, I love to cook. That is one of my favorite pastimes. If I'm not working, I love to cook. And I have gotten so accustomed to incorporating healthy meals into my life that now if I eat a terrible meal, I actually feel really terrible. I actually feel like it's weighing me down, and I get so lethargic, and it honestly makes me want to crave more terrible meals too. So I think it's like one of those things, once you start, you can't just have one. It kind of just creeps up on you.
So we have a concept for that which you described, which is the idea of food as a reward, and food in many ways activates many of the same pathways of reward that, giving a gift to someone does, and that some more potent drugs potentially activate too. So the technical term is the hedonic component of eating from pleasure, because food does give us pleasure, but we have to learn how to control that and make it sustainable for our lifestyle long term. That doesn't mean that you can't have a treat every so often. That's fine, but you have to have the ability to make it up.
Yeah. So would you say that using food as a reward for our kids will actually be will be helpful, or will it not be helpful in the long run?
That's a really challenging question, because the doctor and the parent in me are conflicted. I think we can use it, but to the extent that we can encourage healthier snacks that are part of that reward, the better off we will be. But does my daughter eat ice cream? Yes, absolutely. She will eat ice cream as a treat. She doesn't do it every day. She might do it 1 time a week, and that's okay.
Me too. I do it 1 time, maybe 2 times. So what does patient support look like? And how can we look for support within our own family and our own friends?
Yeah, so patient support comes in many different forms. As you mentioned, I often ask patients to start kind of with their inner circle, because those are the folks that you share your life with, and that will be there constantly to help you and remind you, to care for you. In the age of the internet, there can be groups. I often caution patients about specific ones that would be supportive of a healthy lifestyle, ideally in the context of a nutrition professional. And then in the medical setting, I think, we have a whole branch of nutrition that really is the foundation for a healthy lifestyle. It's difficult to access, honestly. We are fortunate in the veteran systems to have free nutrition, but it is difficult to access. So to the extent that you can educate your immediate circle, be surrounded by kind of a supportive circle of health professionals or folks that promote a healthy lifestyle, I think that's the most effective type of patient support. We also, for instance, run groups of patients that might have diabetes related from their weight or from obesity, in addition to seeing a nutritionist. That can be very helpful to validate how difficult it really is to manage your weight, and how you can learn from each other to manage.
Yeah. Thank you. One more question, and then we want to open it to some questions from the audience. Why, Dr. Aleman, do you think obesity is underdiagnosed and an undertreated disease?
So that is a very interesting question that I often talk about in my medical talks, because that is an issue of the medical community. Obesity was not recognized as a disease, as I defined it earlier, as excess fat accumulation that causes disease, until 2013. So you're very young, Abia, but you were around, hopefully around that time. I was training at that time. So part of my medical training, we did not have the words to describe obesity as a disease, nor did we have the framework to potentially treat it. And for those folks like myself who dedicate to this to even be compensated for our work. So that has really emerged in less than 10 years. The science of obesity existed long before that, but treating it and recognizing it and treating it as a disease is quite recent. Secondly, many physicians aren't well versed in diagnosing obesity or treating the complications. There are very significant efforts to educate my colleagues through the Obesity Society or the American Board of Obesity Medicine, both of which I can highly recommend. The American Board of Obesity Medicine is growing very rapidly, and physicians in just about any specialty can actually learn obesity medicine and apply it to their settings. There are clearly patient issues, right? The word obesity has stigma, as we alluded to earlier, and that can lead to patients not feeling comfortable having the conversation, even when the physician is willing to. And some physicians might not feel comfortable addressing it. So in many of my interactions, I start with asking permission, and I teach that because that's very important. I think you have to ask permission. Can we discuss your weight, and can we discuss how your weight might relate to your health? And if the patient says no, we respectfully move on to something else, because there is real stigma that percolates all levels and that we try to combat. And then the other concerted effort through the Obesity Society and other professional societies is to increase access to anti-obesity medicines. There's a Treat and Reduce Obesity Act that is under consideration by some of the my professional societies that I belong to. And that will, again, increase access and facilitate one part of the spectrum of obesity care that, again, starts from your environment, nutrition, medications, and potentially surgery.
Wow. So, 2013, that's not that long ago.
It is
So
not. It is not that long ago.
So before then, obesity was just,
It was an adjective.
wow.
It was thought of, similar. It's a quality you attribute it to patients, and that's
Yeah.
it's unfair, but that's how it was thought of, unfortunately.
Mm-hmm. Yeah. One thing that I do want to mention is a lot of what the plus size community also is trying to do, which I have always felt this way, is we try to take away the stigma of the word fat. I think people think that fat is like a insult, but really fat is one, it's your fat. It's how much fat you have in your body,
Yeah.
what that may be, but it is an adjective that shouldn't be negative.
Right.
So a lot of the times, I know my colleagues, they try to reclaim the word fat, and I think it has helped because there's a difference between, I think we mix up the word confidence and beauty with health. I think people try to make all those words in one, when anybody, you can be beautiful inside and out.
Yeah.
But just because you feel healthy, it might not actually be that you are healthy, and vice versa. Just because you don't look a certain way, it does not mean that you are unhealthy either.
Yeah.
So we really try to take away the stigma and reclaim our own individuality.
I like that strategy. I'll add that we study fat in the lab. Fat is tissue, just like skin is a tissue. So
Mhm.
it's an organ. And again, part of it is just how the science and the medicine evolved. 30 years ago, we thought it only really was an organ dedicated to storing energy, and that's it. But now we understand that it's a very important organ that makes hormones, that has circulation, so it interacts with the bloodstream, it interacts with your nervous system. So we for us, it's a noun, and it's a noun of a tissue that we study and that we're very interested in.
Mm. Yes, thank you, Dr. Aleman. So we have a question from the audience. This is actually a very great question. How do we combat food deserts in lower socioeconomic neighborhoods?
Yes, so I've learned a lot about this aspect actually since coming to NYU. We have a very strong division of population health that has helped inform some of the decisions at the level of New York City, including some folks from New York City might be familiar with the Green Cart Initiative. So these are carts that would be wheeled to what would be qualified as lower socioeconomic or food desert neighborhoods to make fruits and vegetables available, separate from your supermarket or your farmer's market, so that there was always a ready source of highly nutritious, lower calorie density foods available. Because we know that in those food deserts, the higher calorie, poorly nutritious foods are available. So we just have to make the option available. Other countries have tried things like taxing beverages, and that has some effect. Some cities in the United States have done that with mixed success. Other aspect that I like, and I learned also from my colleagues, is changing how we advertise food. So for instance, I want to say, in other countries, frosted, I'm not going to say a brand, sorry, but some of the children's cereals do not have a character, but just have the cereal in their picture, because the characters really attract the children's attention. Changing how we display food in the supermarkets, even in those food deserts, might help. In other countries, there were examples of, for instance, supermarkets that had the higher calorie soft drinks at the level of children. So children could easily identify them. So if instead you place a healthier option there, the children might be attracted to it. So there's many tools that many of my colleagues are studying. I like the idea of making the fruits and vegetables readily available. There has been some evidence in New York City that it has helped.
That's amazing. We would love to open up the floor for questions if anybody has questions. While those questions come in, Dr. Aleman, I have a question, a personal question for you. How can we try to get those stubborn friends and family members to realize that their suffering with obesity can cause detrimental complications? How can we almost wake them up from?
Yes. So there's some very simple ways that you can do that. There are initiatives, including in New York City and others, to test for prediabetes, because we estimate that due to obesity, about a third of the US population probably has prediabetes. So accessing your healthcare provider or clinics that might screen for some of these conditions, your blood pressure, prediabetes, and if it's occurring, if that health condition is occurring in the context of excess weight, to address it, to say, I think your weight might be contributing to this. Is this something you'd like to address? The Obesity Society and the Endocrine Society have outstanding resources, and the American Association of Clinical Endocrinology all have phenomenal resources for patients, for patient education, to learn about obesity and the spectrum of care, as I mentioned it. And I think at the end of the day, I think the most important is to relate. If you have or someone that has benefited from treating their weight independently or in the concert of a disease, to share that experience. So for that reason, I thank you, Abia, for sharing your own experience kind of in this context. And I thank LULAC for organizing and for putting together resources of how obesity might affect the Latino community.
Yes, thank you so much, Dr. Aleman, for all your insight. Some wake-up calls for me. And I just am excited to be able to apply all this information to my life and to be able to help those around me who are suffering with obesity. I think that if you love someone and they are very important to you, you would want them to live as healthy and as long as possible. So I also do think it is a team effort as well. In closing, I just want to thank everyone for joining us. You can visit our website, www.lulac.org/obesity. Thank you so much. Like I said, Dr. Aleman, please take care of yourselves. And like I said, those that you love. Thank you so much to Novo Nordisk for this wonderful workshop. It has been very insightful, and I'm probably gonna go make a delicious, healthy dinner and work out tonight.
Excellent. Yeah. Thank you for having me.
Thank you, Dr. Aleman.